Sorry guys for
Okay.
yeah.
Okay, so today I'm gonna talk about.
You need to share your slides with us.
Oh, I am. It's just up at, I think it's like in the top corner.
Oh, I see.
You want me to wait or? I can wait, it's okay.
Just since I'm here, let me yeah.
No, it's just.
But
Okay, so I'm gonna talk about sarcoidosis in pregnancy, etiology, pathophys, management, and treatment. So first I'm gonna start off by talking about the incidence and prevalence of sarcoid on a more global level. This figure shows all the studies from different countries since about 1990. And you can see here that the United States is among some of the highest prevalence and certainly among some of the highest incidence globally. Black American women have the highest rates of sarcoidosis, and the age-adjusted specific mortality is higher for Black Americans compared with non-Hispanic white Americans, indicating worse disease prognosis for this patient population. And the highest incidence and prevalence in the US of sarcoidosis is actually among non-Hispanic Blacks, with Black women unfortunately having the highest rates of this disease. And this image here really just depicts the disproportionate effect for Black women in comparison to other patient populations in the United States. And really to better understand the role of race in sarcoidosis diagnosis and prognosis, we need more information to see how long patients had these symptoms before they were able to access care, and taking into consideration social determinants of health and the barriers to accessing prompt health care that can cause worse health outcomes. So the exact etiology and pathogenesis of sarcoidosis really remains unknown, but there are multiple triggers that are proposed that can cause the underlying granulomatous inflammation. That includes environmental exposures, infectious agents, and other endogenous proteins. And I think this graphic does a nice job kind of tying this all together about how it's really multifactorial in combination with psychosocial factors and comorbidities that can result in cardiac sarcoidosis, neurosarcoidosis, skin manifestations, pulmonary manifestations, and eye pathologies as well. And in terms of the contribution of genetics, in terms of studies and the information that we have, familial clustering of disease has seen variations in the susceptibility in different ethnic groups. There's a high sibling relative risk. And then additionally, data from candidate gene studies and genome-wide association studies suggest that there is the existence of some sort of genetic predisposition to sarcoidosis. And then in terms of specific genes involved, there is thought to be HLA class 2 genes involved because they have to do with the antigen presentation and granuloma formation, and potentially class 1 and class 3 alleles as well. However, the studies have conducted have had limited results just because there's highly variable linkage disequilibrium in the HLA region, which really makes it difficult to pinpoint the risk or even protective loci at this region. So it's hard to parse out what the existence of racial, ethnic, and phenotype specific genetic associations are. In terms of the pathophysiology, I think this graphic does a nice job sort of explaining what our idea is of how this works. So normally in a healthy individual, there's some sort of antigen exposure and then the antigen is cleared. But in patients who develop sarcoidosis, there's thought to be all of those multifactorial things going on in terms, and then also a genetic predisposition that for some reason you don't clear this antigen. And so exposure to this antigen then is sensed by the different immune cells like the toll-like receptors and then monocytes and macrophages in tissues. And then they migrate to those tissues where the inflammation is and through antigen presentation and then more pro-inflammatory mediators. There's more T cells that go to that inflammatory site, and then antigen presenting cells along with all of the signals necessary turn the T cells into Th1 and Th17 cells which then are recruited to the lung. And then those cells release more pro-inflammatory mediators like interferon gamma. And then the Th1 cells are releasing the IL-12, IL-18, and other cytokines like IL-2, tumor necrosis, alpha, and then interferon gamma, which just further like ramps up the inflammatory cascade. And then there's several downstream signaling pathways like JAK and STAT signaling. And then all of that combined with the decreased amount of T regulatory cells, this really just contributes to the ongoing inflammation because the T regulatory cells can't really tamp down this immune response. So in terms of the clinical features, pulmonary involvement is the most common presentations present in greater than 90% of those affected. And then it's predominantly like an interstitial lung disease with progressive fibrosis in up to 20% of the people that do develop this condition. And then a subset of those patients will develop pulmonary artery hypertension, which is obviously a contraindication to pregnancy. And so I think this graphic does a nice job of sort of exemplifying how the dysfunction of the T regulatory cells and the increased Th1 and Th17 and the associated cytokines. And then additionally, the factors that lead to fibrotic lung remodeling like TGF beta and other factors like that. You can really see how this cycle down here in the bottom left just continues to go with the hypoxia and tissue stiffness, which then causes more extracellular matrix deposition, and then pro-fibrotic mediators, which then causes fibrotic lung remodeling, and the cycle continues on. So in terms of like a staging of pulmonary sarcoidosis, there are 4 different stages that radiologists will use to identify where the disease is. And it's important to know that it's not really a worsening progression of disease in terms of the stage. It more just identifies where they're seeing the sarcoid within the lung and on a radiograph. So there really is no significant progression between these except for stage 4, which indicates fibrosis, which is reversible. So that is the most severe, even though this isn't really like a progression. It's just to identify where the disease is. And then in terms of extrapulmonary feature skin disease is the most common. The specific is lupus perinea, which is in the bottom left, and then the other non-specific, erythema nodosum multiforme, and then the nummular eczema. And you can also see this in joint, liver, and eyes, either with arthralgias, hepatic granulomas, and hepatomegaly, and then anterior uveitis, which would present with pain, redness, and photophobia. And then in terms of the presentation in the cardiac setting, up to 50 patients can experience cardiac symptoms. Sometimes this can manifest as syncope in patients with no known cardiac history. And this really all stems from the infiltrative myocardial disease and formulation of granulomas along the electrical conducting pathway of the heart, which can lead to life-threatening arrhythmias in 2 to 7% of the patients, causing sudden death. And cardiac sarcoidosis can also lead to different forms of cardiomyopathy, myocarditis, pericardial effusion. And I think this image on the right is like a good depiction of the different methodologies you can use to analyze the heart in the setting of sarcoidosis. You might see increased atrioventricular block or ventricular arrhythmias, and then on echo, reduced ejection fraction, thinning or thickening of the septum, and then segmental dysfunction. And then you can also use PET scan and MRI to visualize the heart. And PET scan can show you like the uptake and also the metabolism going on, whereas the MRI will just sort of show you like where the lesion might be. And then in terms of
our clinic, Dr. Jones prefers the PET scan.
Yes. And then in terms of the neurosarcoidosis, this can present in 5 to 13% of people, with most commonly cranial nerve palsy, unilateral or bilateral. and then optic nerve dysfunction as well. And you can also more rarely see like diabetes insipidus if they have depositions in the HPA axis, hypopituitarism, and then meningitis, peripheral neuropathy, and these different distributions. So just other things to keep in mind. So sarcoidosis in pregnancy. A lot of what we know about is from 2 cohort studies, one done in the United States and one done in Sweden. And these studies looked at intrauterine fetal demise, preeclampsia, gestational hypertension, diabetes, and all those other factors listed there. And I think it's important to think too about how the sarcoidosis affects the pregnancy and how the pregnancy is also affecting their pre-existing sarcoidosis. And this image does a nice job of kind of like visualizing this concept. So sort of as I was talking about before, when in pregnancy, when there's the increased T regulatory cells, these can really tamp down the Th1 and Th17 cells. So some patients might actually see an improvement in their sarcoidosis or potentially no change at all in their presentation. However, those that start off at a more severe level, either with severe interstitial lung disease or cardiac sarcoidosis, they can see worse outcomes just from starting off sicker at baseline before they're beginning their pregnancy. And then in terms of the effects of sarcoidosis, these studies have seen increased fetal growth restriction, increased DVT and PE, and then also an increased risk of preeclampsia. And this table just sort of highlights what these 2 studies found. So neither one showed a significant increase in intrauterine fetal demise. Both showed an increase in preeclampsia, no differences for gestational diabetes or gestational hypertension. The Hadid et al. Study did show increased DVT and PE, but there were no reported cases in the kosher et al. And some thoughts about this are that there was more cases that were labeled at the time of delivery. So potentially they were having more active disease that indicated induction or delivery. And so potentially they were sicker patients from the beginning. And then also Hadid et al. Showed increased fetal growth restriction. Both studies showed increased preterm delivery, both for cesarean section as well, and then increased postpartum hemorrhage in Hadid et al. And then there was also this abstract presented last year at SMFM, and it was a 20-patient retrospective study for patients delivered between 2010 and 2021. They were included if they had a biopsy-confirmed diagnosis or met criteria for neuro or cardiac sarcoidosis. And at the time of diagnosis, most of these patients had biopsy-proven disease. It's kind of small, I don't know if you can see, but on the left table. And half of these patients required medical management prior to their pregnancy, but interestingly, none of them required therapy during their pregnancy. And for these patients, around 70% of them were delivered by cesarean section at term, so they were able to carry the pregnancies to term. And what they found was an increased postpartum hemorrhage and cardiovascular compromise, with some patients developing peripartum sarcoid cardiomyopathy. And then in terms of the neonate, increased congenital heart disease and lower birth weight were found in this population. So this was potentially a good launching point for other studies. And so this was the patient that we had seen in the clinic. I won't go too much into her detail, but she has a history of sarcoidosis. She's at 17 weeks and 4 days. She has been feeling increasingly short of breath for the past 2 months and was noting some increased chest pain with the shortness of breath. And then her history, essentially, she'd been on methotrexate and prednisone for 2 years, never felt that it controlled her symptoms, switched to IV Remicade, which is infliximab. This really improved her symptoms as well as her chest imaging, but then she self-discontinued the IV infliximab, and now, because she felt so much better, but now she's really managing her disease with Advair and albuterol at the moment. So in talking about preconception and baseline management, if they are on mycophenolate mofetil or methotrexate, it's important that be stopped for mycophenolate at least 6 weeks prior to pregnancy and methotrexate at least 4 weeks prior to pregnancy. And then good labs to get are CBC, CMP, calcium, and then ACE levels. And then for cardiac, baseline managed, like a baseline EKG, an echo, and then a Holter monitor if they are symptomatic with palpitations. And then in the preconception setting, you can consider the PET scan of the heart, which is what Dr. Jones seems to prefer, because you can see both the location of the disease as well as the metabolism. So sometimes you can even see the response to treatment based on improvement of the cardiac PET scan if they do have cardiac sarcoidosis. And then additionally, like I said before, if they have severe ILD or symptomatic cardiac sarcoidosis, it really warrants like a risk benefit discussion with multidisciplinary people and the patient to decide if they really should embark on pregnancy and if it would be safe. So for her, she got an EKG, she had a CT of the chest, and this really wasn't like intentional preconception testing. It was just sort of what she had gotten from following with her pulmonologist. And so then in terms of intrapartum management, you really want to optimally control their disease before they get pregnant. That really is the key. For flares, high dose steroids, and then for maintenance and suppression, it's really like a low dose steroid with one of these drugs below. Obviously, they can't do methotrexate or mycophenolate. So the two options are infliximab or azathioprine if they need some sort of maintenance medication. And so those are two options for maintenance. And then talking about the safety of long-term corticosteroids, because they would need to be on those either in a high dose for a flare or a low dose for their maintenance. There were some studies that showed a potential increase in fetal cleft palate, but more recent studies really haven't demonstrated this. And there also has been no shown increase in fetal growth restriction or preterm delivery. And the consensus about GDM is that some studies showed that there was an increase with long-term use, but there really isn't enough solid evidence to determine whether these could really contribute to a development of gestational diabetes. And then just a little bit about the safety profiles of infliximab and azathioprine. Infliximab seems like really the best choice if you need to use one of these. It potentially could increase the risk for preterm delivery and fetal growth restriction, but it's hard to say because it potentially could be the conditions that this medication is used to treat. And there's no evidence that breastfeeding is contraindicated, and there's been no like negative long-term effects on the child, either developmentally or in terms of their immune system. And then azathioprine, again, increased preterm delivery and potentially low birth weight, but also could be the conditions that the medication treats. And then in terms of breastfeeding, 4 hours after the last dose, the medication content has shown to be very small in the breast milk. And most babies that have been exposed had normal blood counts and really no higher rates of infection. Some studies showed that higher doses for certain conditions may be associated with like temporary issues with the immune system, and low blood counts in the newborn, but more like research is really needed about this. So in terms of intrapartum management, if there's a cardiac complaint, like it's the usual workup that we would do. But then a 1 week Holter monitor can really help, and it's what we are going to do for this patient because you can see if there's any arrhythmias that are going on that could indicate like sarcoid, along the electrical conducting pathway of the heart. And then a cardiac MRI could be considered, but like Dr. Jones was saying, it doesn't seem like it's the best study because you can't see the metabolism, and the risks and benefits of gadolinium have to be weighed since it can cross the placenta. And then in terms of neurologic complaints, an MRI can be helpful to determine if there's neuroinflammation, and then pulmonary complaints, LFTs can monitor for disease progression as well if they have baseline LFTs. And so, like I said, we got a 1 week Holter monitor for her, and then her pulmonologist ordered some of the specific labs that they like to use, like the CMP and ACE, except some studies were saying that ACE can be increased in pregnancy at baseline, so it really might not be the best lab metric to monitor disease progression and severity in this patient population. And then in terms of intrapartum and delivery management, because these patients can be at higher risk for fetal growth restriction, growth ultrasounds at 28 and 36 weeks can be a good idea just to monitor for the development of that. And then if their disease becomes poorly controlled, following along with the guidelines for the complication that develops, whether that's preeclampsia or growth restriction. And that the same goes for antenatal testing, and likely starting around 34 weeks to make sure that everything, that the fetus is still doing well. And then delivery timing, there's really no indication for preterm delivery unless a complication were to develop, like I talked about previously. And then finally, like postnatal management considerations, you really have to be cautious of a flare, because pregnancy is really a time of like an anti-inflammatory state. And this is beneficial because it maintains tolerance to the fetus. So after the delivery of the placenta and fetus, there's a pro-inflammatory environment that returns, and this can result in the patient experiencing a flare, which would be treated with high-dose steroids. And again, there's really like the pregnancy hormones really lead to a shift in this Th2 response, which potentially sort of tampers down the Th1, which is really linked to autoimmune diseases, which is, there's some theories out there that that's why these Th1 mediated autoimmune diseases sort of can ramp down in pregnancy and then flare up once they've delivered. And then importantly, like a contraception discussion. And then in our patient's case, we'll get a PET cardiac scan for her and see if she has any signs of cardiac sarcoidosis that really helps to dictate future pregnancy recommendations for her. And that's it.
You guys talk about, sorry. Did you guys talk about anticoagulation for her this year? Or sorry, 2 days ago?
I don't think we did. Yeah, I think we talked about like the general increased risk of.
Yeah. Dr. Bullock and I, saw her for her very initial consult, and we were debating, just given the Hadid paper findings, like with the increased risk of VT, I think was one of the most significant findings they had. If she warranted prophylaxis for 6 weeks postpartum.
Yeah, I think what we said was just like in the context of other risk factors, like a C-section.
She's had like non-vaginal deliveries, right?
Yeah.
So unlikely, but yeah.
We had a patient with sarcoidosis delivered last year, I believe. I think her name was Maldonado. Do you remember her? She had a sarcoidosis, lung and neurosarcoidosis that had, I mean, she looked usually normal to us, but the neuro evaluations were like diminished capacity, always watching this patient, so never leave her alone, watch the baby, thing like that. So it could affect any organ, and sometimes this is to keep an eye on this disease that it always may look like only lungs, but actually until you had a PET scan, you never know what other organs are affected. And the heart seems to be very challenging because the arrhythmia could be lethal, and then you have sudden death, and there is not much you can do.
I think, one of the things I want to emphasize, which you covered beautifully, by the way, is, infliximab and the therapies. To give an example I talk about all the time, many years ago, lupus, we didn't treat with anyone, then Plaquenil came around, everybody was afraid, and we know it's safe. It's much, much better now, with Plaquenil. And sarcoidosis, I think, hopefully it's the same thing, so part of what we need to do is to convince other people who are treating them, like, she stopped. She shouldn't have. And that's kind of your calling in your career, making sure that. So you first ask the rheumatologist, whomever, what you ask them. The most important question, she's pregnant, she's pregnant. What do you ask?
Yeah, I would say like, what's the standard of care?
Correct.
We did reach out to pulmonology on her, and they did get back to me, and they said that they don't think her current symptoms are the sarcoid. They do think it is asthma.
Yeah. And again, that's fine. We have a patient who was on hydroxyurea, sickle cell. The sickle cell people don't want to treat there, but she was on hydroxyurea before, so they thought she was hydroxyurea. So you're going to hear it all the time. I feel, the fellows know, extremely, extremely strong about this. Pregnant people, if you talk about racism, it's much worse for pregnant women. They are undertreated, underdiagnosed, ignored. Nobody wants to see them. Nobody wants to get sued for a pregnant women issue. And, 99+% of medications and things we're doing in general in medicine are safe. Some are not, and we know them. But it's really our thing to say, because otherwise, you got 2 people who are going to be sick, like look at all the complication for, severe sarcoidosis. So just keep that in mind, You can only do what you can do, but I am not afraid to prescribe infliximab if nobody wants to, prescribe hydroxyurea, prescribe whatever, Again, Plaquenil, we were some of the first people to treat, many, many years ago. Nobody wanted to use Plaquenil. It's like night and day, for lupus. So you really can make a huge difference advocating for. Sorry, I took on a. Great. All right. Should we move to 9:30 on the dot? To therapy. And another thing, an announcement as she's bringing up the slides. Neonatology could not be here today because of coverage and holidays and stuff. So let's hello and happy holidays to everyone, but there will be neonatology updates.
Okay. Hi, I'm Sophie. I think most people here know me. This is a presentation about fetal spine anomalies. There's some genetics in here, but a lot of it is going through the embryology, the normal development of the spine, and then what happens when some things go wrong. The spine is very complex, which is the reason why I wanted to go through it just for my own learning. And I don't have time to go through everything today, so I'm gonna pick a select few anomalies, and then I'll finish the rest. Okay, so I'm gonna start with a case review, go through embryology and anatomy and approach to imaging, move on to kyphosis and scoliosis, tethered cord, sacrococcygeal teratoma, and then diastomatomelia. And then part 2 will be spina bifida and caudal regression syndrome, which will probably take a little bit of that. So we'll start with the case review. This patient is a 29-year-old, she's a G1P0. She presented to us at 21 weeks and 5 days, dated with an embryo transfer date for an anatomy ultrasound. Her pregnancy is complicated by twin gestation and IVF. She didn't have any remarkable medical history. She previously had 1 hysteroscopy. She wasn't on any significant medication. She was taking progesterone at the recommendation of her infertility physician. And she did have a low risk NIPT that demonstrated a dichorionic pregnancy, XX and XY. And then on ultrasound, twin A appeared normal. When we moved on to twin B, there appeared to be a posterior. So this is a transverse view of the fetal head. So on ultrasound, the ventricles appeared enlarged bilaterally, and the posterior fossa was concerning for a Chiari-2 malformation with hindbrain herniation and a reduction in the CSF spaces that we might see. And then as to follow any brain abnormality, a careful examination of the spine was performed afterwards. And these are in order: sagittal, coronal, and transverse views of the fetal spine of twin B. Again, this fetus is about 21 weeks. These demonstrate a lack of skin covering over the lumbar spine at about the level of L5.
You want to show for everybody else?
Sure. So here's where the defect seems to start. You can tell that like a sagittal view is not always the most ideal for looking at, especially it's not the most ideal as I'm going to for looking at lack of skin covering. Here, so this is taken from a cine clip, but this is not the cine clip. But if you were to see us coming in and out of this coronal view in the clip, you would never really see this area become like opaque as you would expect with vertebral bodies and a skin covering. And then this is the axial view, and you can see kind of here there's a gap in where the skin should be covering the lumbar spine. Get into this more. So she was suspected to have a meningomyelocele or a myelomeningocele, and then she was subsequently referred to CHOP due to this concern for discussion of for an MRI, and then discussion of potential in utero treatment. So 23 weeks and 5 days, she has her MRI. The Chiari-2 malformation is confirmed, which is seen in almost 100% of meningomyelocele. This confirmed the brain findings, but the evaluation of the spine was limited by maternal inability to tolerate the MRI. But through subsequent ultrasounds, CHOP does confirm our initial suspicions. She elects to continue her pregnancy, and she does transfer her care from us to CHOP. At about 25 weeks, she has a consultation with pediatric neurosurgery, and they advise her that she is not a candidate for fetal closure at their fetal center because of her twin gestation. Well, that is something that they offer the Singletons at CHOP with meningomyelocele. And then Our last growth ultrasound was actually performed 2 days ago at 30 weeks and 5 days and demonstrated normal growth of both twins, normal fluid and Dopplers, and there was movement and normal positioning of the lower extremities of twin B, which is always good. Their plan, per their notes that I can see, is to continue to do an ultrasound assessment every 2 weeks and deliver at 37 weeks via a primary C-section in their special delivery unit. So I'm going to talk about embryology and anatomy of the spine. And just as a refresher, a lot of these terms are going to be used in subsequent slides. So I just wanted to go through them because I don't think about these things on a daily basis and hadn't thought about them in a while. So there are 33 total vertebrae in the spine, and some of them are fused. So there's 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 5 fused coccygeal. The nerves exit the spine below the level of the vertebrae. The tapered end of the spinal cord is called the conus medullaris, and in typically developing adults, this is located above the L2. The cauda equina is the bundle of nerves that continues caudally after the spinal cord terminates at that level. Then the filum terminale is the fibrous band that connects the conus medullaris to the dural sac of the coccyx. So back to some of the basics of embryology. When the 3rd week of embryologic development approaches, we have a bilaminar disc that evolves into a trilaminar germ disc. The trilaminar germ disc involves the ectoderm, the mesoderm, and the endoderm. The mesoderm forms a hollow central tube called the notochord that extends along the long axis of the embryologic disc. And then around day 18, the notochord and the mesoderm induce formation of the neural plate. And then around day 21, the process of neurulation begins from the neural plate, which will give rise to most of the central nervous system. Neurulation happens in 2 stages. So primary neurulation is the formation of the spine cephalic to the conus. And then secondary neurulation is the formation of the spine caudal to the conus. So primary neurulation, this occurs between days 18 and 28, and it begins with the formation of the neural tube and then the neural crest cells. So the neural plate folds and elevates. It forms this kind of trough area that's called the neural groove. As the neural folds fuse, but prior to the fusion, the neuroectoderm gives rise to these things called the neural crest cells. These neural crest cells will eventually migrate to various parts of the body to form the autonomic nervous system and some endocrine glands. The cranial and caudal ends of the neural tube are referred to as neuropores. And these will begin to close at the kind of moving outward at the brain and ending with the spinal cord. The hollow neural canal will become the ventricular system of the brain. And then the central canal of the spinal cord as well. So this junction is the final phase of primary neurulation, and this occurs when the neural tube separates from the underlying ectoderm. And if disjunction goes wrong, that's when we actually see the neural tube defects and other spinal dysraphisms, which is just a general term for defects with So secondary neurulation occurs between days 28 and 48. This involves the posterior neuropore forming into the primitive streak, which is also referred to as the caudal cell mass at the caudal end. The primitive streak forms the distal neurotube, and this eventually becomes the conus medullaris, the cauda equina, and the filum terminale. So in general, secondary neurulation is a far less precise process than primary neurulation, and it can lead to a wider range of malformations, such as a tethered cord, caudal regression, and a sacrococcygeal teratoma. So following secondary neurulation is a long process of deemed like spinal cord ascent, which I had no idea that this happened. So this begins at 12 weeks as the conus medullaris ascends or moves cranially and the filum terminale elongates. So this process eventually also forms the cauda equina. The conus continues to ascend until about 2 months postnatal when it reaches its normal resting place between L1. So moving on to vertebral body development. This process happens simultaneously to the central nervous system development, and I'll go through in the next couple of slides. I think Dr. Goularton was the first person to point this out to me, why the fetal spine looks like 3 pieces when in adults it does not, and it was totally the development and ossification of the fetal spine is why this appears to exist in 3 parts on ultrasound, at least in our transverse view, and then ossification is how it eventually becomes fully bony in the adult spine. So as a reminder, our spinal vertebra generally consist of a flat and wide vertebral body. This is connected to the spinous processes via pedigals and laminae. And then these structures house the spinal cord and the hollow center here. The vertebral body separated by the discs is how we get our flexibility in most of our spine, and shock absorbing nature. So these vertebral bodies are all separated by a cartilaginous intervertebral disc. So vertebral body development starts with the cartilaginous stage. The notochord induces the surrounding mesoderm to form these things called myotomes and sclerotomes. The myotomes will form these paraspinal muscles that allow us to be upright, and skin that eventually covers the cord. The sclerotomes form the vertebral body, the intervertebral disc, the meninges, the spinal ligaments, the posterior spinal elements. Eventually the notochord will degenerate and involute where it is surrounded by a vertebral body, and then this remnant of the notochord becomes expands and becomes these intervertebral discs that we need. Chondrification centers eventually appear, and then the vertebral arches fuse. And failure of the notochord induction leads to kind of incomplete division of the neural plate, and then this can lead to neuroenteric cysts or dysteatom. Everything is hidden. Okay, so the next stage of vertebral development is the ossification stage. This starts about week 8 and actually continues into adulthood. This is when the vertebral body forms from fusion of the ventral and the dorsal primary ossification centers. At the end of the embryonic period, there are 3 primary ossification centers for each vertebra. And this includes the central part in the vertebral body and then half of each vertebral arch extending laterally. Ossification starts to be visible at week 8 and just becomes more and more prominent as it develops. And then at birth, each vertebra consists of 3 bony parts connected by cartilage. So this is why in an axial view, the spine appears like 3 symmetric parts. A central ossification center, and then the vertebral body flanked by the ossification centers in the vertebral arches. And then failure of the vertebral bodies to segment can lead to things like block vertebra and hemivertebra. So how do we approach the fetal spine? AIUM requires documentation of the fetal cervical, thoracic, and lumbar spines, at least in 2 planes. So our practice here is a sagittal view and an axial view. And then oftentimes due to fetal movement, this requires cine clips in order to assess the entire spine. So at 16 weeks, vertebral ossification is starting to become very apparent. This is 16-week fetus here. And then by 20 to 24 weeks, the entire bony spine can be imaged on standard views. And then in the 3rd trimester, a more detailed bony anatomy of the spine, including the pedigals and laminae, the transverse processes, and the spinous processes start to become apparent. So the top image here demonstrates a normal sagittal view. The middle row are normal axial views here. And typically you can either have a still image at each level of the vertebra, or you can have a sweep through the whole thing. I think we all probably prefer a sweep. And then this is a typical coronal view. Here.
Do you know if other places prefer coronal view over?
I know at least where Dr. Goularton trained, coronal view was standard. I think here our practice is to obtain a coronal view when we have suspicion for an abnormality. more in retrospect. So, as I said, on the axial view in the second trimester, 3 ossification centers can be seen. So you have these 2 lateral masses and then a central vertebral body. The lateral masses are composed of the transverse processes, the spinous process, and the articular process. The 3 ossification centers form a triangle with the lateral masses, so they form a V-shaped tent over the spinal canal. The cord should be completely enclosed by this triangle, and the entire length of the spine should be imaged in the transverse plane, because this view is best for highlighting any splaying of the vertebra, any asymmetries, and then potential neural tube defects. And then those can be further investigated by additional views. So the sagittal view here should demonstrate 2 parallel curvilinear echogenic lines. And then there can be variation in fetal position. But in general, there are 3 gentle curves, so cervical lordosis, thoracic kyphosis, and then lumbar lordosis. And sometimes you need to image multiple times to ensure that the curvature appears normal, and it is very dependent on where the probe is in relationship to the fetal body. The coronal view is useful for evaluation of the vertebral body anomalies when they're suspected, as well as potential scoliosis. So a normal ultrasound appearance of the posterior elements in the coronal plane is 2 paired echogenic lines. This is a 3D view here, which widen in the cervical spine, and then they're less wide in the lumbar spine normally. And 3D imaging is also very useful for anomalies, especially if you're unsure with your 2D images. So some quick notes in approaching the fetal spine, some good questions to ask. This came up a couple times for me even this week. So is the alignment normal? Abnormalities of spinal alignment can be transient, they can be fixed. So it's important to evaluate the spinal position over time. Is the overlying soft tissue intact? So amniotic fluid should be visualized between the spine and the uterine wall to ensure that the overlying skin is intact. You can get like a compression of especially a cystic defect over the spine if the spine is pushed up against the uterine wall, and you might miss it. So although the defects are more common in the lumbar spine, they can also affect the cervical and thoracic spine. So that's why it's important to sweep through the spine and an axial view completely. Is there a spinal mass? So cystic posterior masses might indicate a meningocele, a meningomyelocele that contains neural elements, terminal myeloceles. Solid masses might include a cord lipoma or a sacrococcygeal teratoma. Is the brain and the posterior fossa normal? So as we know from our case, nearly 100% of QRE2 malformations of the brain are associated with spina bifida, while most will have a protruding sac. An open defect without a covering can easily be missed if an evaluation of the distal spine is not performed after brain evaluation is abnormal. And then you want to ask, where is the conus? So eventually the conus will be around L2. A tethered cord is seen often with neural tube defects, both open and closed. It can also be seen in the factorial association and in kyphosis and scoliosis. And assessing where the conus is kind of best done by identifying the 12th rib and counting. And then lastly, are there any additional anomalies? Vertebral body anomalies are features of factorial association, and a complete evaluation of the spine should involve counting all the vertebrae if you suspect that there is an anomaly. So we'll start with kyphosis and scoliosis. So this is when it evolves from a failure of vertebral formation, segmentation, or abnormal fusion. It's kind of a catch-all term. It can involve an anomaly in any vertebral body that creates an abnormal spinal position. Scoliosis is abnormal lateral angulation. Kyphosis is abnormal anterior angulation. And then you can see them both together in kyphoscoliosis. On imaging, this defect can occur anywhere along the spine in single or multiple levels. You can have an acute angulation problem, as you can see in this video. So as we go down into the lumbar spine, you see that normal 3 kind of vertebral tension go away and the spine begin to curve laterally. This is a axial sweep. So you can see acute angulation, or you can see long abnormal angulation, which can certainly be harder to pick up on as it is more subtle to our eyes. The kyphosis and scoliosis is a result of vertebral body anomalies. This is most commonly seen in hemivertebra. There are 4 different types of hemivertebra characterized by the presence or absence of a normal disc space adjacent, above and below the affected segment. So you can have fully segmented, which is the most common, semi-segmented, which is here, non-segmented, and then incarcerated, which is the least common. Other possible vertebral anomalies include a butterfly vertebra, which is seen here, which results from non-fusion of the central component of the vertebra. And the scoliosis that results from this is usually not as severe because the defect is central in nature rather than hemivertebra, which is on one side or the other. Block vertebra, as seen here, are also possible, and this is when 1 or more vertebral bodies are fused, resulting in a large rectangular vertebra.
Sorry, how would the butterfly look on ultrasound?
You would see it as, I think, an ossification defect in the middle, so it would like have dropout in the central vertebral body. And then in the presence of vertebral anomalies, block vertebra. So in the presence of vertebral anomalies, it's also common to see rib fusion, and that's demonstrated here. And that can be a problem for lung capacity. So the diagnosis of kyphosis, scoliosis, hemivertebra in general are more common in diabetic mothers. The epidemiology of hemivertebra is about 1 in 1,000. Or the frequency. Isolated hemivertebra is more common in XY fetuses, and then multiple vertebral defects are more common in XX fetuses. On imaging, this is a coronal view. It's an X-ray. But you want to identify the level of the defect by using the ribs to identify the 12th thoracic level. And you always want to look coronally when you're suspecting a defect on ultrasound, and also utilize your 3D imaging. Persistent scoliosis and kyphosis are a high suspicion, should elicit a careful search for additional vertebral anomalies, and any vertebral anomaly should prompt a careful search for a neural tube defect and then brain anomalies. And then if you suspect a complex anomaly or multiple anomalies, an MRI can be helpful as the soft tissue resolution is a bit better. And we get away from some of the challenges that we have, say with like maternal BMI and other issues, limiting our views on ultrasound.
So for the ribs, is that more of like a MRI issue, or is that something you would look for on ultrasound too? I don't feel like I've ever really
missed on ultrasound.
I don't think I've ever, I mean, other than like rib shadowing when I'm trying to look at the heart, I don't think I've ever really thought about ribs on scans.
Yeah. It's one of the most frequently missed associations with vertebral anomalies is rib fusion, because it's difficult to see.
Does that help you prenatally with identifying the level of it, or is that more of like a postnatal X-ray sort of?
If the rib fusion is so bad that the thoracic circumference is low, then that can be really impactful for postnatal cyst, which I think I talked about later.
No, I was more thinking like, because you said that like in terms of like determining the level, the ribs are what will help you determine the level of the defect. Is that something that's postnatal will help you determine the level, or is that something we should be looking for when we see these defects on scans? Like
for example, if you see a defect and you think it's in the lumbar spine, you should try to have a view where you can identify where the 12th rib is, because that's the last thoracic vertebra, and then count down from there. So that when you're writing your report or communicating to your referral center, you can say the defect appears to be at L4.
Gotcha.
So that you're not just like, it's in the lower spine. You can say that. It sounds smarter. Okay, so isolated kyphosis or scoliosis has no associated increased risk for any pallidity that I can find, but non-isolated is associated with a few genetic changes, including one in the 9q33, 1q34.11 deletion, a micro deletion, which I'm sure Claire knows all about. The this microdeletion is associated with intellectual disability, developmental delay, especially concerning for speech delay, microcephaly, short stature, strabismus, and seizures. Associated anomalies are seen in about 60 to 80% of cases with kyphosis and scoliosis, and then they are frequently missed in terms of rib anomalies. Since we are usually so focused on the vertebral anomaly, we don't look at the ribs, and the ribs are very difficult to assess with ultrasound alone due to shadowing. Spina bifida is the most common cause of congenital scoliosis. Also present may be cord tethering or a syrinx, which is a just fluid-filled elongated sac in the spinal canal. Additional genetic associations that you might see include a bacterial association, which is characterized by vertebral, anal atresia, cardiac malformations, a TEF, renal and limb abnormalities. Alagille syndrome, which is characterized by neurologic sequelae, butterfly vertebra, liver abnormalities, cardiac abnormalities, and then ophthalmologic abnormalities. Clinical field spectrum, which is characterized by few cervical vertebra, a short neck, GU, and cardiac abnormalities, and then spondylocostal dystoses. These are characterized, it's also referred to as Jarko-Levin, characterized by spine, rib abnormalities, thoracic insufficiency, and then respiratory compromise as a result of that.
We recently did have a patient who underwent microarray due to hemivertebrae, and she was found to have a 16p, I think it was a 1-2 microdeletion, where it was associated with like mild, like variable expressivity for like intellectual delay, developmental delay. And mom had scoliosis as well, but mom had negative testing, but Huda was like, are they connected? Let's get her an MRI, of course.
And I'm sure that, like, as with that patient, there's many people who are found to have like mild scoliosis in childhood who just never get genetically, analyzed. So outcomes of in management of hemivertebra is really highly dependent on whether or not it's part of a larger syndrome or isolated. And overall, fetal hemivertebra is associated with an increased rate of preterm delivery, cesarean delivery, growth restriction. Syndromic or hemivertebra has a higher rate of mortality than isolated. But if the case is isolated, it can be significant and the patient can be delivered for OB indications. As for prognosis and treatment, so this is also really dependent on whether or not additional anomalies are there and whether or not there's concern for thoracic insufficiency based on rib fusion and chest circumference. So these children often require postnatal imaging. The prognosis of isolated hemivertebra is overall good. But if left untreated, about a quarter of patients with congenital scoliosis don't have any progression, 50% progress slowly, and 25% progress rapidly as they grow as children. So the treatment for this is corrective surgery for significant or progressive curvature, which may include spinal fusion or vertebral resection, depending on the etiology, and then an expansion thoracoplasty may be required for thoracic insufficiency when rib fusion is present, and that's highlighted here. So you can have pretty significant fused rib findings that So moving on to tethered cord. So this is defined as a low-lying conus for gestational age. Some define it as a conus medullaris that's inferior to L3, L4 at 18 weeks. So the conus does progressively ascend the spinal column normally. So there are landmarks for normal ascent throughout fetal development. By 19 to 24 weeks, it should be at L2, L3, and then 24 weeks above L2. The best plane in which to image the conus is the sagittal plane, and then again, identify your 12th rib, and then count and this is a coronal view of the spine showing an inappropriately low conus here. So you can see it's at the level of the sacrum, which it should be.
So I'm just gonna make a quick comment just to draw attention, especially for the fellows. This is something we don't do, routinely, but there is a lot, and I'm sure you'll go over it more. There's a lot of literature on this, and some places, like in Europe, etc., do look at this routinely to try to increase the sensitivity for neural tube defect and other things. Just something that I think I will bet in the next 5-10 years that it will become more routine in the US as well. So kind of get used to this. This is not esoteric or just interesting. I think that this is something that will become more commonly, routinely done.
I don't know that I did the deep dive that you're looking for, Dr.
Say it again?
But this is really interesting. I did not realize that this was even something that we could see on ultrasound.
If you look for it, you can see it.
Yeah. And that the association was so high. I don't think I've ever commented on a conus. I don't know if Sarah, if you have. Yeah.
No, never even looked for it.
You will.
So, and this is why. So it's frequently associated with other spine abnormalities. Almost 100% of neural tube defects have a tethered cord. It's also seen in conjunction with spinal dysraphism, so other bony defects, intradural processes, genital scoliosis and kyphosis, and 40% of those with bacterial association, and about 10% of those with anal atresia. So in isolated cases with no other findings, it's difficult to diagnose in utero, probably because it's not standard of care to look for it. And so it's typically diagnosed postnatal or even into adulthood, which can pose problems because it can become progressively symptomatic. So postnatal presentation, you might see a midline cutaneous skin stigmata. This might look like a nevi, lipoma, tufts of hair, hemangioma, dermal sinus. The child may have urinary dribbling. You might see a clubbed foot. Hopefully we picked up on that in utero, a leg length discrepancy, muscular atrophy, or mild scoliosis. It, like I said, can progress to become more and more symptomatic over time, especially if it's undiagnosed. So in children, this results in incontinence. In adults, this can present as pain, gait spasticity, weakness, atrophy, and that atrophy may not be reversible. And then the treatment of this involves basically a release surgery and re-anchoring of the phylum, as well as correcting any potential underlying pathology that may be there. Treatment of the associated pathology is essential for a potential complete resolution. And this is just a picture of the phylum tagged with the vessel loop. Our last topic here is sacrococcygeal teratoma. So sacrococcygeal teratoma, I know that Dr. Bender has had a case of this from VCU, but it's the most common congenital neoplasm, which I had no idea.
But it might have been when you were in.
I think so. She was delivering a section. I'll get it.
It's huge.
Yeah, it was huge. So it's generally a benign neoplasm that is derived from all 3 germ cell layers. It doesn't look benign when you look at it on ultrasound, but it is by definition benign, but recurrence with incomplete resection and malignant transformation are very possible. About 80% of these are in the coccygeal area, and it's thought to derive from incomplete regression of the primitive streak. So remember that, secondary neurulation, and continued division of pluripotent cells that have migrated from the yolk sac to the genital ridges. So like I said, it's the most common neonatal tumor, which I really did not know. The prevalence is reported as 1 in 40,000 live births with a female predominance of 4 to 1. The fetal prevalence is most likely higher, though, more like 1 in 10,000, considering the high number of in utero deaths, stillbirths, and terminated pregnancies that go unreported. So On imaging, this usually appears like a large mid-axial exophytic mass at the fetal perineum. It extends from the sacrum, and it may be entirely external, internal, and external in equal parts, mainly internal or entirely internal. At our prenatal ultrasound, the majority of these are seen as a solid, mixed, cystic, and solid caudal mass. Only small portions are entirely cystic, although in general, the prognosis is better when there are more cystic than solid components. A really important fact about these tumors is that they have a potential for extremely rapid growth, and they require rapid or frequent assessment with ultrasound. About 10 to 40% are seen with additional malformations, and these can include hydronephrosis, renal dysplasia, a lower urinary tract infection, or ludo, anorectal malformations, hip dislocation, and clutch feet. So this tumor, as with some other large, potentially vascular tumors, and this is a fetal MRI on the right, can be associated with high output cardiac failure, and I had no idea about this. Risk factors for this include a large, fast-growing tumor with signs of intramural hemorrhage, high AFI, increased placental thickness, a high CT ratio, and of course, high drops that can result as a sequelae of this, and that's estimated to occur in about 5 to 20% of cases. So as such, these cases should be followed really closely, particularly if the tumor is large, vascular, and solid. There is a tumor volume to fetal weight ratio that can be calculated by taking the tumor dimensions, multiplying them as about 0.5 and dividing them by the estimated fetal weight. If prior to 24 weeks, this ratio is greater than 0.095, this is predictive of poor fetal outcomes. That number is a more universally accepted number. Well, there's more recent data to suggest that fetal tumor volume fetal weight ratio greater than 0.12 is overall predictive of poor fetal outcomes and maternal operative risks. So these poor fetal outcomes are things like fetal intrauterine demise, neonatal demise, fetal deterioration warranting an open fetal surgery, and then fetal deterioration warranting delivery prior to 32 weeks. The majority of these cases are also sporadic. There is a rare autosomal dominant disease called Currarino syndrome. It's associated with a triad of a presacral mass. It's not always a sacrococcygeal teratoma, but it can be. Sacral agenesis with a sickle-shaped pelvis, and then anorectal abnormalities. There are also some associations seen with urinary duct abnormalities in this syndrome, or in this disease, and a variable developmental delay. So management of a sacrococcygeal teratoma will really depend on how big it is and what else is happening. So in general, you might need to, if there's very significant poly, which is a poor prognostic factor, you might need to amnio reduction. It's very symptomatic. Aggressive surveillance should be done for high drops. Usually this is with weekly ultrasounds. Fetal surgery may need to be considered, and referral to the appropriate center for prognosis. And then the ideal delivery timing is really unknown. Some centers recommend a late preterm delivery, early term for all fetuses affected by this, but some centers will go by the tumor fetal weight ratio. Some delivery considerations are that, especially with a large mass, you may have a labor dystocia, and cesarean is often recommended for this reason for large tumors. In addition, the trauma of a vaginal delivery may cause tumor avulsion and capsular rupture, which can lead to fetal exsanguination. Another reason why cesarean delivery is frequently recommended. Maternal complications of this can be wide-ranging from hyperemesis, preeclampsia, Muir syndrome, and preterm labor. So an option for treatment of select patients with a sacrococcygeal teratoma is fetal surgery. This is offered at CHOP. These pictures are directly from their website. And this is an appropriate referral on diagnosis, but especially if suspicion for high output cardiovascular compromise is found. So the options for treatment include open fetal surgery, where the external component is completely removed with fetal surgery, and then the post needle surgery is needed to remove any internal components if it exists. There is a risk of incomplete resection and local recurrence or malignant transformation with this, and then of course the risks associated with any kind of fetal surgery, such as preterm delivery, infection, intrauterine demise. Pedoscopic and laser ablation with radiofrequency ablation and or coiling is also being investigated for this. So in 2014, there was a systematic review published looking at about 20 cases of this. So 6 out of 20 of the hydropic fetuses referred survived after minimally invasive therapy. That was about 30%. 5 of the 11 survived radiofrequency ablation or interstitial laser ablation for these inappropriately large blood vessels leading to the high output cardiac failure. 8 of 12 fetuses treated for the sacrococcygeal teratoma without obvious hydrops survived. So if hydrops is, you get to them before hydrops is present, that seems to be better for overall prognosis. The mean gestational age after of delivery after minimally invasive therapy was about 29 weeks, plus or minus 4 weeks. And survival after open fetal therapy and hydropic fetuses was about 55%, similar mean gestational age of delivery. So I think the consensus is that minimally invasive options may be more helpful, but unclear if they're better than an open fetal surgery option. If open fetal surgery is not an option, then basically become the only option. Sacrococcygeal teratomas have a overall survival rate of about 50 to 75%. And again, this depends heavily on whether or not there's hydrops. 20% of these kiddos have long-term functional disorders such as incontinence, weakness, constipation. As I've said, there is a risk of malignant transformation in adulthood. This is not diagnosed properly, resected. There's 4 different types depending on whether there's an internal component and an external component, one or either. And then treatment, regardless of whether or not there's fetal surgery performed, is postnatal surgery as well. And then alpha fetoprotein is the tumor marker associated with germ cell tumors, and this is often followed for a local recurrence risk. The last group defect I'll talk about is diastomatomelia. So this is a spinal dysraphism that occurs essentially when there's a spinal canal spur that splits the cord into 2 hemichords. The prevalence rate makes it seem pretty common, but I'm not sure if anyone here has seen it. 1 in 2,000 to 1 in 4,000 live births. It contributes to about 5% of congenital scoliosis cases. It's associated with scoliosis mainly, although it's a central defect, so the scoliosis may be subtle. It's seen with a tethered cord. It's syringohydromelia, myeloschisis, myelomeningocele, lipomeningocele, and then a Chiari-2 malformation, about 15 to 20% of cases. On imaging, the best plane, this is an MRI, but kind of funny. The best plane is the axial plane. You might see an echogenic focus in the posterior spinal canal between the laminae. It's easy to miss if it's small. On a coronal view, you'll see widening of the canal. On a sagittal view, you might visualize possible vertebral anomalies, although sagittal is really not the ideal group for this. And then the skin overlying is usually intact. On MRI, you might see uniting of the hemichords above and below the spinal cleft. This is a better way to evaluate the filum terminale and the level of the conus. And then it's also useful for associated masses in the brain if you have concerns for that. Some of the clinical issues with this, so there's two types. Type 1 that has a separate dural sac and arachnoid space with a spur present, and then type 2 that has the same dural sac and arachnoid space with no spur. It may be harder to pick up on. And then the natural history and prognosis. So the symptoms that these kids have is related to the degree of tethering. A lot of them might have movement problems, urologic dysfunction. Although the prognosis is overall favorable when isolated. If there's a tethered cord present, then treatment involves a cord release, a spur resection, and then the dural repair. And when performed early, this can lead to decreased symptom progression and overall a better prognosis. And as with most things, we recommend surgery before you have deterioration of function so that there's no or less rehabilitation needed. It's a lot of long words. Okay, so spinal anomalies part 2, spine bifida-caudal regression syndrome will come in my next fetal therapy in April. These are some of my references. Lots of facts to say that.
It was great. Any questions? This is pretty complex. I guess, you'll cover it maybe next time, but any of the fellows, like, what's the sensitivity of, regular ultrasounds, even without some of these fancy views like the conus, et cetera, for NTD?
I mean, I think it depends on the degree of the neural tube defect, the timing of the scan, and the.
Yeah, it would take, 3 million, plus, pregnancies in the US and, it's green.
Our overall rate of detection for anomalies period is around 70%. So I would guess less for neural tube defects.
It's actually 95%. If you get, 2 of the views, like, coronal, sagittal, whatever. And for example, MSAFP is also 95%. So for example, in Europe, they don't do alpha-beta protein anymore because they think that they're so good at ultrasound that they have given up. I know Dr. Kowatlis really, pushes that, because we're not 100% as good as we can be. But it's actually one of the, cardiac defects, probably 50% we miss unless we do an echo, and that gets over 90%. But in general, if you're doing, it's like cars, sonographers and certified and whatever, it's pretty high. You don't get them all. And obviously the small ones you're saying and the ones that have been covered. But the open defects. Yeah. Other spinal defects, like, hemivertebra, things like that. And that's why people are coming up with this idea of the conos and, other things that are other tricks, so to speak.
So I think the MSAFP in our patient population,
Thank you.
the application is really because our patient populations is different than the Europeans. Our BMIs is very high here compared to their BMIs. It's really difficult. And many times when you cover anatomies, we send patients, we say, okay, we can see your spine. And here you go, you're 22 weeks and you have zero information on the spine. So that's why really implementation should be 16 to 18 weeks on all our patient population here. And, in places where the average BMI is pretty high. So, yeah. So fascinating topic, Dr. Green. You were very thorough, very extensive, very detailed. We learned a lot from you. Please send us your slides.
No, thank you, Dr. Quality. I also, are the genetic students still on? I'm presenting that SMA case at a CHOP case review in January, along with some genetic counselors from CHOP Neurology Division, and some of the neonatologists at CHOP. So that will be on January 15th. It might be interesting from a genetics perspective.
Yeah.
I can share that information with you guys.
So it's the students' winter break now, and that's why most of them were not present. I think I saw 2 or 3 So, but basically it's the vacation time. But
Yeah,
hope
I'll share it with you, Dr. Alcala.
you share with the slides, and I plan to send them out. If you can include the email for the CHOP lecture for you too also. Thanks.
I'll be sending recording of this lecture this afternoon.
Thanks, Amanda.
When you talk to CHOP, they've done more cases of sacrococcygeal teratoma, surgery when the report is, like, they need to report cases, or more, you only presented 20 cases, reviewed the literature, there are all the centers that do it should be.
Yeah.
So, because they do offer it, you're right, especially eye drops, large. Any other questions? All right. Am I doing section next then?